Hello everyone, I'm Sarah Jewell, the Assistant Director of Clinical Services and Manager of the Myra Mahan Patient Resource Center. I'm thrilled to welcome you to another health seminar at the MMPRC. The Myra Mahan Patient Resource Center aims to make accurate, science-based health information easily available so that patients and their families can make informed decisions about their care. Through its collection of online databases, pamphlets, and staff, the center aims to live up to its namesake, Myra Mahan, who lived from 1937 to 2011, a licensed clinical social worker who believed that an informed patient is almost always a healthier patient with a better chance for a favorable outcome. Access to medical information helps patients overcome their fears, she said, while providing comfort and at many times acceptance of treatment. The PRC works collaboratively with the world-class physicians and healthcare providers at Weill Cornell Medicine, who are committed to delivering outstanding primary and specialty care to all patients. The center opened in February 2007 through generous donations from the Arthur and Myra Mahan Foundation, the Adrian and Jesse Archbold Charitable Trust, and the Dean's Challenge Matching Funds. And now I'd like to introduce our speaker today for our seminar on new therapies for spinal stenosis. Dr. Daniel Pack did his anesthesia residency at Weill Cornell Medicine and pain fellowship at Brigham Women's Hospital, Harvard Medical School. He was previously on faculty at Massachusetts General Hospital, Harvard Medical School. He returned back to Weill Cornell Medicine, where he is now the Associate Program Director of the Cornell Tri-Institutional Pain Fellowship and Director of Practice Innovations for the Pain Division. Please welcome Dr. Pak.
Okay, so everyone can hear me okay?
Yes.
All right. So it's a pleasure to be with you all today. Thank you for coming, especially when the weather isn't so great outside. Now, as previously mentioned, my name is Daniel Pak, and I'm one of the chronic pain folks at Weill Cornell and also at the Opt Spine Center. And the subject matter that I'm going to be talking about today is spinal stenosis, which is in a lot of ways a buzzword within the spine community, and certainly you may have been told that a friend or yourself or someone else that you know has this diagnosis of spinal stenosis. And as a matter of fact, it's probably the most common diagnosis we see at the Spine Center on a daily basis. So the purpose of today's presentation is to kind of go over the basics of spinal stenosis, so what it is, and also talk about some of the newer therapies that are now available. And certainly my hope is that you can come out of this with some more information and also a good idea of what are the potential treatment options. These are my disclosures, but none of which conflict with our subject matter today. For the purposes of this discussion, I will be talking kind of generically about therapies, and we'll be avoiding specific manufacturers or device companies. So we'll be talking more generically in terms of those things. Now, here are the discussion points. We'll be talking about, among other things, what does the spine look like? What does it do? What are the basics of spinal stenosis? What are some of the diagnostic tests you might encounter? Traditional treatments, and also some of the newer therapies that are now available. If you need any clarification on the slides, you can just say something. We will take, as was previously mentioned, some questions at the very end. The one thing I will ask is avoid any personal questions or patient-specific questions, because we want to avoid talking about patient healthcare information. But otherwise, I'd be happy to answer your questions afterwards. Okay, so this is what the spine looks like. And some of this will be review for many of you. But the spine is essentially comprised of multiple sections. You have the cervical spine, the thoracic spine, and also the lumbar spine. And the cervical spine generally relates to kind of the neck area. The thoracic spine is the mid-spine, and the lumbar spine is the low back. And all those areas are made up of multiple components. So you have the vertebrae, which are essentially the bones that support the rest of the body. Those are connected to each other by facet joints, and the joints allow you to essentially flex and extend, twisting motions, etc. The intervertebral discs, which you can see is this structure here, essentially like a shock absorber for the spine, right? So when you hear about herniated discs, that's what they're oftentimes talking about. And the spine is really important for supporting the body, but also is really important as a structure to protect the spinal cord and also the nerve roots that come down. And the nerve roots come out of the, let me see if I can get the pointing device working there. You can see that area right there. Basically exits the spine through this area called the foramen, right? And then you have a complex of ligaments and muscles that attach to various areas of the spine and are really important not only in terms of movement of the spine, but also as a supporting structure, right? So the muscles serve as essentially like a cage for the spine, in that it prevents the spine from moving outside of the range of normal motion, and as a result prevents you from injuring your back, right? So when people are talking about I strain my back, that is oftentimes what they're referring to. But the muscles are really important to protect yourself. So a very complex structure. Now you can develop spinal stenosis in any one of those regions, the cervical, thoracic, and lumbar regions. For the purposes of this discussion, we will be focusing on lumbar spinal stenosis because that's probably the most common cause and what we see most often. The lumbar spine is made up of 5 vertebrae, L1, 2, 3, 4, 5, and is associated with 5 pairs of descending nerve roots. So the left and right L1 nerve roots, L2 nerve roots, etc. So when you have a doctor who says you have a problem at L5S1, L4, L5, that is referring to essentially which area of the spine is there an issue. And if they say you have some impingement on the L1 nerve root, the L2 nerve root, that's what that's referring to. So just some background and some context of what we're talking about here. Now spinal stenosis is essentially a progressive narrowing of the spinal canal. It's usually degenerative in nature. And this process is chronic. So for the most part happens over decades and decades of time. It's usually not acute. Some patients will have something called congenital spinal stenosis, which essentially means you're born with a narrower spinal canal. But when you have this narrowing of the spinal canal, what it essentially does is it compresses the spinal cord and the nerve roots that go down. Okay, and it's pretty prevalent. You can see the statistics here. It affects about 11% of adults in the United States. Over 20% of adults over the age of 60 have some degree of spinal stenosis. Now, let me preface this by saying 80% do not require treatment. So just because you have spinal stenosis doesn't mean that your symptoms is coming from the spinal stenosis. And most people, in fact, don't require any treatment, right? So spinal stenosis in a lot of ways is a radiographic finding, meaning these are things that we see on something like an MRI, but that doesn't necessarily have to correlate with the symptoms that you have. But having said that, it is by far the leading diagnosis for patients undergoing spine surgery over the age of 65. Now on the left you see is a diagram of essentially what a healthy spine looks like, and then on the right what you might see in spinal stenosis. And there are many causes for spinal stenosis. So you can have degenerative disc disease. So I'm going to use my cursor here. So if you can see that, degenerative disc disease, disc herniation, disc protrusions, disc bulging can all crowd the space of the spinal canal. In addition to that, you can have bone spurs or arthritis of the facet joints that can also crowd the space. There's also a ligament, that's not shown here, but a ligament that lines the back portion of the spine that we call the ligamentum flavum. It's almost like a callus. And so it's a callus that over time gets thicker and thicker. Again, all of these elements can contribute to this diagnosis of spinal stenosis. Now there's also different types of spinal stenosis. So central stenosis is referring to narrowing of the canal, and you can see on the left diagram, narrowing of the canal where the nerve roots and spinal cord descend, go down. Lateral recess stenosis is usually referring to narrowing right before the nerve roots exit the spine. And foraminal stenosis is talking about narrowing along as the nerve roots actually exit the spine. So generally speaking, central stenosis usually presents as patients having back and leg pain that go down both legs, whereas lateral stenosis and foraminal stenosis usually presents as pain that just goes down one leg. Now the caveat to that is most people have multiple different types of stenosis. So yes, there are patients who just have lateral stenosis, and so as a result, they have pain that just goes down one leg. But for most people, we see patients with all three different types. So there's a lot of variability in terms of symptoms and presentations, right? So not, the human body doesn't follow a textbook, and every patient presents a little bit differently. Now here are the symptoms of spinal stenosis. Classically, people will describe pain that goes down the buttock, leg, and calf. Most people will describe it as kind of a burning sensation. Some people even will say it's a heavy sensation. My legs just feel heavy, right? For most people, that pain is worse when walking and standing, and it improves with sitting and leaning forward. And what you see on the slide there is what we call shopping cart sign, right? So if you go to the supermarket and you see a lot of people leaning on their shopping cart, maybe they're tired, right? But it may also be because they have spinal stenosis. And the reason for that is because when you're in a sitting position, when you're leaning forward, for example, that oftentimes creates a little bit of space in that spine and can give you a little bit of relief. So what we often hear is patients who say, I have no problem sitting, but I can't walk. A lot of patients will also say, I can ride my Peloton bike, or I can do a recumbent bike for 3 miles, 5 miles, no problem, but I can't walk more than 2 city blocks. So that is kind of classically what we oftentimes see in spinal stenosis, and is key. And as the stenosis gets more severe, patients can also develop, among other things, numbness, so numbness of the lower extremities, and also weakness when the cases are particularly severe. So patients will say, I can't lift my thigh up, I have a foot drop, I'm dragging my feet, etc. Now when you go and see your doctor, they take a history and they do a physical exam and test strength, etc. But another thing that they will oftentimes get is imaging. And you can get a CT or MRI. MRI is really the gold standard. And the reason for that is because an MRI allows us to see the anatomy, the structures surrounding the area, where the stenosis is occurring, and what is causing the stenosis. And this is typically what we see, and we'll go over some MRI images in the next several slides. But MRIs are extremely helpful for us. Nerve conduction studies can also be done as a matter of to kind of rule in and rule out other types of etiologies or different causes of leg pain that can oftentimes cloud the picture. But for the most part, MRIs are really what we get for most patients. Now on an MRI, we grade the stenosis from essentially what's normal all the way from then mild and then to severe. If you look there onto your left, let me just orient you so using the cursor again. So this structure here, this is as if I cut your body right in half from the top. Okay. So here is a normal looking spine. And you can see this structure where my cursor is, that's usually the discs. This Y-like structure here, those are the joints and the lamina of the spine. This middle structure is really what we're looking at. Whoops. And that's what we call the thecal sac, and that's where it's essentially filled with water. It's a protective structure for the spinal cord and also the nerve roots. And off to the side is where you see the nerve roots exit. And what we're essentially looking for in this case, and you don't have to be a radiologist to figure this out, is how patent does that look? How does the canal look? And this looks pretty good. And as you go to your right, you can see that that center structure gets narrower and narrower, right? All the way up to the point where you see in a patient with severe stenosis, that thecal sac is essentially obliterated, right? So you don't see a lot of white there anymore. Now, traditional treatments fall into a few different buckets. Physical therapy, medications, interventions, surgery is something we kind of look to as a last resort. And what we generally recommend patients is certainly to start with the most conservative options first, but in addition to that, to really take a multidisciplinary approach. And what we mean by multidisciplinary approach is try to get at the pain from a multitude of different therapies and treatments. So physical therapy in conjunction with medications and other types of interventions to help your symptoms. Now, the reason why we emphasize physical therapy, and a lot of times when I suggest physical therapy, I get a lot of eye rolls, is because it's super important for strengthening the muscles surrounding the spine. I described earlier that those muscles of the spine are really a supporting structure. It protects the spine from, again, different types of motions that would potentially cause injury to the nerve roots. It can also relieve nerve compression in different areas. So physical therapy is extraordinarily important. It can help with things like posture, leg strength and mobility, and for a lot of patients with spinal stenosis, they're extremely deconditioned because they're not walking much, right? So they really lose a lot of strength in their legs, and so we recommend physical therapy to regain that strength. And the one thing we hear from a lot of folks is that, I go to the gym all the time and it never worked. I have a trainer, it doesn't help. And what I will say is that the muscles that we are trying to work out in physical therapy is entirely different from what you would do with a trainer at your gym. And that's because these muscles that we're trying to essentially strengthen, the core muscles, the muscles that surround the spine, are not activated voluntarily. Meaning, you can't go to a gym, work on the row machine, which traditionally is thought of as a back exercise, or doing lateral pull downs, for example, because those muscles are not what we need for the spine. Those muscles are great as vanity muscles, but not great for strengthening the core. And so these muscles are activated involuntarily, and so exercises that a physical therapist can specifically help you with. In addition to that, physical therapy certainly takes time. And I would not expect someone to go to physical therapy for 2-3 sessions and get better. And as a matter of fact, I would expect you to feel worse after the first several sessions, because just like anything else, you are activating or working out muscles that you have not traditionally had to exercise. So it does take time. And it's certainly something that we recommend people do as a kind of the first line therapy. Even after we do all these treatments, we recommend physical therapy because it is something you have to continue doing. Now, medications can also be helpful, and these are medications you might have heard of. So non-steroidal anti-inflammatories, that's like your Motrin, your ibuprofens, etc. Not great taking that long term, however. It causes a lot of issues with stomach irritation and kidneys. Anticonvulsant medications like gabapentin or Lyrica, those are actually used off-label. Those medications are essentially anti-seizure medications that we now give off-label for nerve pain issues. The side effects from these are not negligible, meaning you can feel a little bit sleepy and foggy, and so for that reason we oftentimes start people at a low dose and continue to titrate up or increase the dose as appropriate. Antidepressants, believe it or not, are also often used off-label. We are not psychiatrists, so if you get better mood from the medications we give you, great. But in this particular case, we're using it for pain. And medications like duloxetine and Pamelor or nortriptyline are now, to be quite honest with you, most commonly used for different types of nerve pain issues as opposed to as an antidepressant. And also muscle relaxants can also be used for patients with muscle-associated pain. Now, medications have their limitations and are good adjuncts, however, does not get to the root of the underlying problem. Right? So spinal stenosis ultimately as a diagnosis is an obstructive mechanical issue as opposed to something else. And so I think medications are helpful and certainly we're open to it. However, I'm always very honest with people to say, look, this is oftentimes not the answer. Right? And lastly, surgery. So surgical candidates are people who essentially have tried the conservative options and their symptoms are refractory to it or still persist despite everything else that they've done. Other key things that we look for is weakness. So again, foot drop, you can't lift your legs. Any kind of bowel or bladder incontinence is suggested that you should actually probably pursue surgery. Other things like spinal instability, and if the stenosis has gotten so severe that now you have spinal cord compression, these are also reasons why to pursue surgery. Now, the traditional surgical treatment for spinal stenosis is something called a laminectomy procedure. And I'm not a surgeon, so I'm probably not the best person to ask about all the surgical options, but traditionally what is done is, again, spinal stenosis is a mechanical obstruction, and so I just told you that there's compression of the nerve elements, so conceptually it should make sense that the therapeutic treatment for it, or the surgical treatment, would be essentially removing those elements, so now that spinal cord and those nerves can breathe, and that's what it kind of looks like on this diagram. Now, in years past, and I think traditionally speaking, That was not a small procedure. There was a rehabilitation period that was required. But the one thing I will say is that over time, just like the things that we've been doing in pain management and in original spine, those surgical procedures have really gotten less invasive with less recovery time, with smaller incisions. And so oftentimes these big fusion surgeries and these big laminectomies are not necessary, right? And so they've gotten much better in terms of being more conservative and doing less invasive surgery. But this is essentially what is oftentimes offered as surgical interventions. And then there's the interventions that are somewhere in between surgery and like physical therapy and the medications. And these are minimally invasive interventions or injections. And one thing that is very commonly done for spinal stenosis is corticosteroid epidural steroid injections. People talk about cortisone injections, that's oftentimes what they're referring to. Those injections are done in the epidural space of the spine. That's why it's called epidural steroid injections. And epidural just refers to the area where we place the steroid or the medication. And the epidural space is where there's a lot of inflammation because of how tight it is. And so as an anti-inflammatory, we give steroid therapy. So oftentimes can give some symptom relief. And it serves two purposes, one of which is certainly to give you some relief of your pain, so a therapeutic utility, but also it's diagnostic in nature, meaning is the area where we're injecting, is that even the cause of your pain? And so serves those two purposes. For the most part, this is a minimally invasive procedure that takes about 5 minutes. Most of the time this is done in the office under local anesthesia. No sedation is required before it. And most people leave the office that day and can go about their business without having to worry about side effects, etc. And what this picture is showing is that I think the nuances aren't necessarily important, but there are essentially kind of two ways where we can do an epidural steroid injection. You can do something called an interlaminar injection. If your doctor says we're going to do an interlaminar injection, it means injecting into the central canal itself, and then there's a transforaminal approach where you inject closer to the nerve points. So that's just referring to where you're making the injection. I think most of the time people just say, I'm getting an epidural, so you may not know exactly what kind, but certainly you can ask your doctor where you're doing the epidural, and they should be able to answer that question for you. Now, what are the pros and cons? Because I think a lot of people want to know about that. And epidural steroid injections are by far the most conservative intervention that we offer. Very low risk profile. As I mentioned before, pretty much no recovery time. As a matter of fact, a lot of people go to work afterwards, and it's done under local anesthesia. It doesn't require sedation. Now, the downsides to that injection is that it's palliative in nature, meaning it does not solve the underlying problem. When you do an injection, it works great as an anti-inflammatory in that area. It does not get rid of the stenosis. So a lot of people will ask, is my stenosis going to get better? Is my degenerative disc disease going to get better with the steroid? And the answer is no. There's also issues with durability of the therapy, meaning how long is it going to last? And a lot of people will ask that question. My goal when we do the injection is always to get, if I can, 6 to 8 months out of that injection. And for some people, it lasts longer. For some people, it can be shorter. Right? So you have to be okay with that fact. And unfortunately, there is not a lot of predictors in terms of who responds better than the next person. Right? So generally, 6 to 8 months is what we hope for, but can always vary. And then the question of repeat steroid use. So you can do repeat injections. We generally try to limit it to every 4 to 6 months. But repeat steroid use over a very long period of time is not great. And so steroids can cause issues with bone health. Also, you may have heard of people having an increase in blood sugar. So if you have diabetes, it can cause an elevation of your blood sugar and also elevation of your blood pressure. Those are usually transient in nature, so it doesn't occur for a long time afterwards, but it can occur. So those are always things that you should be aware of when you're doing this type of procedure. That then brings us on to, I guess, the newer emerging therapies that can be offered, and one of which is what's called a percutaneous image-guided lumbar decompression. Some people call it PILD, or even a mild, so minimally invasive lumbar decompression. And this is a procedure to debulk or shave the ligamentum flavum. And I mentioned earlier, the ligamentum flavum is this structure here, And it again, it's like a callus that lines the backside of the spine, and over time gets thicker and thicker, like a callus, right? And this is not a process that happens overnight. We're talking about decades and decades of time. But what this procedure does is to try to address this area specifically by shaving that ligament. And this is what we see on an MRI. So if you look at the left panel, I guess your left panel, the ligament is this black structure here, right where those arrows are. And for a normal person, that thickness should be about 2 millimeters. In a patient with ligamentum hypertrophy or a thick ligament, that can be anywhere from 5 to, I've even seen 8 millimeters, right? So 3-4 times the size. And again, you don't have to be a radiologist to figure it out. You can see the arrow right there, that black is much thicker, right? So that's how we make that diagnosis. Now what the procedure entails is essentially, it's an outpatient procedure. It takes about an hour or so. Does not require general anesthesia, meaning it's the same type of sedation you would get for, let's say, a colonoscopy, so it's what we call a deep sedation. And that's oftentimes favorable because general anesthesia usually requires you to be in recovery for longer and cause nausea, vomiting, etc. So usually it's always preferable if you can do a non-general anesthetic. And usually what's involved is doing the procedure with 1 or 2 small 1 centimeter incisions. And oftentimes all you need is a little bit of skin glue and a Band-Aid afterwards. And it's an X-ray guided procedure, right? So it's a good alternative to a traditional laminectomy. Now, one thing I will say is that this procedure is certainly not perfect, and it does not address other elements of stenosis that patients have. So if you have stenosis because you have a lot of osteophytes or bone spurs, or if you have stenosis because you have a whopping disc herniation, this procedure does not address that type of stenosis. It really addresses stenosis that just comes from that ligament. And what we see afterwards, conceptually speaking, is something like this. So now that area that was previously narrow because of that really thick ligament, if you have shaved enough of the ligament, you can really allow that area to breathe a little bit better. Now, I like to go into the data without going too much into the weeds. This was a Cleveland Clinic study done on this procedure specifically, looking at 1-year outcomes. And what is significant here is, certainly we want to see patients get better pain relief. But pain, as you know, is a subjective measure, right? So if I tell someone, what is your pain? Someone's 10 out of 10 pain or 8 out of 10 pain is very different from another person's 8 out of 10 pain. It's very hard to objectively compare those two. So what is oftentimes really helpful is then looking at other markers that are more objective, like how much are you walking now? And you can see patients had significantly improved walking distance after the procedure after 1 year. Same thing with standing. How long are you standing? So a lot of patients with spinal stenosis say, I can only stand for 10 minutes and I got to sit down, so I can't wash kitchen dishes, I can't brush my teeth, I have to sit down. And you can see here that patients are demonstrating a lot more improvement in terms of how long they can do those things. If we're asking about pain relief, the outcomes of that was essentially, I think, 50 to 60% pain improvement in terms of their baseline pain score. So again, what are the pros and cons? The benefits here is that it's a minimally invasive decompression. So again, 1 or 2 small 1 centimeter incisions. People always ask, what does the recovery period look like? For most people, some soreness in the back for a couple days is what we generally see. But after that, there really are no limitations to what you can and cannot do. And as a matter of fact, most patients, while we certainly give patients the option of getting pain medications afterwards for just a short course, a lot of people will come back and say, I never used the pain medications. The complication risk is lower compared to traditional spine surgery. There is no implant, meaning we leave nothing behind. Right? There's no hardware that's left behind. And this does not preclude your ability to do anything in the future. So a lot of people will ask, if I do this, does it mean I won't be able to do X, Y, Z in the future? And the answer is no. You can still choose to do surgery later if you decide that is the right route, or any other intervention that I might talk about. You can still do those things after you do this procedure. And previously, I included insurance coverage because a lot of the newer and emerging therapies have difficulty with insurance coverage. And then this is essentially covered universally along all Medicare plans and also Medicare Advantage plans. And the reason for that is actually because of a Medicare-sponsored study that was done on this. And so the data is quite good for something like this. Now the cons, because we should always talk about that, as I mentioned before, this is a limited decompression, meaning, again, it does not address other areas of stenosis. Some people will come to me and say, well, look, I read the brochure, I went on the website, it says 100% pain relief the second I walked off the table. Generally speaking, that's not what we see. 100% pain relief would be great. Most of the time, my goal all the time is to give you increased benefit. Something above 75% is what I would hope for. And again, improve functional metrics, so you have to be okay with that. It's also not meant for any patients with neurologic issues, meaning if you have a foot drop, if you have weakness of the hips, for example, typically this is not the procedure for that. This is really for patients who have mostly pain as their primary issue. And I won't get into the specifics, but if you've had a history of a previous lumbar fusion, lumbar spine surgery in a particular area, you may not be able to do this procedure at that same area. So it's just something to be aware of. Now, another therapy that has really gained popularity and has that we've started to offer patients is something called the inner spinous spacer. And this is actually an implantable device or an implantable spacer. You can see it on the right image there. And what it does is it essentially is placed in between the spinous process of the spine to prevent extension and narrowing of the spinal canal. So in this particular case, what it does is it kind of lifts the spine and prevents and creates space that way. Now there's many devices on the market. The one that is most commonly used is this one right here. You can see these wings. And it's a titanium implant that's placed through a very small incision. Now, very similar to the previous procedure I described, this is an outpatient procedure, usually about an hour or so. For most patients, and again, I'm speaking generally, does not require general anesthesia and can be done under some kind of deep sedation or sedation through an IV. 1 or 2 small incisions are usually all that's required, and the recovery period is, again, usually some soreness after a few days, but certainly people are walking out of the procedure and you're not bedbound. And this is an implantable procedure, meaning, again, this is a little bit different in that we do leave a device behind, but it is removable. You can take it out. Now, again, the data, right? So what we see here is some pretty good pain improvement at 5 years. Right, so 66% improvement in back pain, significant leg pain, and also as a pain provider, we love to see patients coming off their medications, right? And you see an 85% of opioid reduction in those patients who are on opioids. Okay, pros and cons. So a lot of which I've already talked about. The difference here is that this device is a little bit different than the MILE or the PILD or the MILE procedure. This does address the stenosis that occurs off to the side. So remember we talked about different types of stenosis, central canal stenosis, lateral recess stenosis, foraminal stenosis. This addresses better stenosis along where the nerve roots actually exit, whereas the MILE does not do that as much. And again, it's an implant, but it's removable. Now the cons here are patients with osteoporosis or osteopenia, morbid obesity are generally speaking not candidates for this procedure. There is a very small risk of spine fracture that can occur with the device itself, and usually that's more in patients with a history of osteoporosis. And you cannot do it at every single level of the lumbar spine. It's just a matter of technique in terms of where you can actually place the implant. So that would be something that you'd have to talk about with your physician. And then I won't go into too much detail about spinal cord stimulation, but this is an implantable therapy that essentially sends electricity onto the spinal cord to relieve pain. And What's involved is there's a battery that's attached to these two wires, and that does stimulation of the spine. It's very similar, and the way we kind of equate it to is like a pacemaker for the spine. The kind of interesting thing here is that you can actually do a trial period beforehand, meaning we can place the wires into the spine. Usually that can be done on an outpatient basis in the clinic, and we tape the battery to the back, and it's like test driving a car. So you can really see, is this something that's beneficial for me, without any commitment of having to go through with the full implant procedure. So you can make a decision regardless of how the trial goes, whether you want to proceed or not. And this has been something that patients really have preferred and liked, because if your surgeon told you I can test drive the surgery and you can see if it's going to help you or not, a lot of people would take that option. And so you do a trial beforehand. And this is going a little bit more further into kind of the mechanism of action, but essentially what's done is there's an electrical field that's created around the spine, or around those leads, by designating, there's contact points on there, and designating one as a positive and negative, like a battery, and on a cathode, and that's what generates the electrical field. So benefits here is that this is an outpatient procedure. Again, the ability to trial is something that a lot of people like. It's been widely used for decades, and so the most common application for this is actually in patients who had failed spine surgery in the past. So have back and leg pain after spine surgery. That is the most common application of this, but the clinical indications has really drastically increased over the last several years. And the devices have gotten remarkably more complex and advanced. Just like your iPhone, you can update these platforms remotely, and so just because you get a system one year and they get the new system the next year, oftentimes you can just update it remotely instead of having to buy a new one or get a new one. And ultimately, it's meant to be permanent, but it can be removed. Now, the downside here is that it does not address any of the anatomical issues. So it doesn't address the stenosis directly. It doesn't give you space in the way that the other treatments do. There is a little bit of a recharge burden, meaning just like your iPhone that you have to charge every night, you have to charge this device too. Depending on how you use it, that recharge burden, how often you charge it can vary. Some people only charge it once every several weeks. If you're using a high energy program, then you may have to charge it once every other day, but that really depends. And any device-related issues that can occur, it's not often, but if that happens, that would be something you have to deal with. Okay, so, for the longest time, we had essentially kind of two options, which was you could try the most conservative treatments, so do physical therapy and medications, and then you had surgery. And for a lot of people, that did not really fit within their lifestyle of what they wanted to do. And so there was a big treatment gap of what could be offered for patients. And this is kind of a really exciting time to be in the interventional spine space, just because everything in medicine is kind of going towards offering patients less invasive options than whatever was done traditionally. And the several therapies that I talked about towards most recently addresses that gap. And so now we've been able to treat patients with less invasive therapies than traditional spine surgery and given them a lot of function back, which is always our goal. Okay, so before we go into questions, here are some common questions we got asked in the clinic. Okay, so we're going to answer these first. So the question is, when should I see a doctor? And the answer to that is if you have these symptoms, that's a good time to get to see a doctor, right? Because usually, even on the first visit, a diagnosis can be made, but usually there's diagnostics tests that are made, physical exam has to be done, and also there's a lot of other types of conditions that can mimic spinal stenosis, right? So what you don't want is to kind of go down the spinal stenosis route, and it's actually a problem that has nothing to do with the spine. So a physician can help you make that diagnosis, and I think that's a good time if you have these symptoms to see a doctor. A lot of people ask, should I see a surgeon first? And I think that's somewhat of a nuanced question. Surgery is done usually as a last resort. And if you talk to most of our spine surgeons here, I think they're excellent in that they are conservative and think very intentionally about all the factors that go into play. And so most of the time they'll say, well, look, you need to try some of the more conservative options first, whether it's physical therapy, medications, injections, etc. But the nuance to that is if you are, if you're having issues in terms of bowel and bladder incontinence, the weakness in the leg is getting progressively worse, that's a good time to see a spine surgeon. All right. What do I need for my first consultation appointment? If you have ever had an MRI before, if you've had an X-ray before, it is always very helpful to us if you bring two things. One is the report, and the other one is the actual imaging CD. It's very helpful to have both, because one tells you basically what how the radiologist interprets the images. The other one is the actual images themselves. And so we always like to see both of those things. It's always very helpful also, we see a lot of patients who've seen other providers in the past, have already had procedures done in injections, to have a sense of what has been done so we don't repeat those, right? Because the last thing you want to do is go through years of doing a bunch of injections that never worked, and for us to try to repeat those things. I think it's always in our best interest to do something new and to do something different. And so if you have previous documents or previous procedure reports, that is always very, very helpful to us. A lot of people say, I can't get an MRI. Can I just get an X-ray? And an X-ray is great to see the bones. It's great to see alignment. It's helpful, but it does not tell us usually most of what we need, which is an MRI. Now, there are patients who cannot get MRIs for one reason or another. There's some patients who have heart implants or a cardiac pacemaker, for example. In those cases, sometimes we can get by with something like a CT scan, but an MRI is still, in a lot of ways, the gold standard. A lot of people will also say, I can't sit to do an MRI. There are other options out there, meaning there are open MRIs, there are stand-up MRIs for people who are claustrophobic. For patients who can't lie down, we can do those types of things. So it's really important to let us know, and we can usually figure out a way to work around whatever issue that you may potentially have. Do I need to do physical therapy? And I think I've hopefully given you my thoughts on physical therapy and why I think it's so important. We generally will always recommend this. And one thing that we commonly encounter is in patients who've had some of the treatments that I described, they'll come back and say, look, my chronic pain is much better and I'm walking a lot better now, but I have this new pain now. My calves are kind of sore after I walk. And my answer to that is, in the absence of a new condition that you've now developed, it is probably because you are not used to using those muscles now that you're walking more. Right? So if you're telling me, my legs, I have new aches and pains in my legs that I didn't have before, then oftentimes even physical therapy at that point afterwards to improve your conditioning is very, very helpful. So a lot of people will still engage in physical therapy afterwards. So certainly there are a lot of physical therapy facilities around the city. Oftentimes, we also have one associated with Weill, Cornell, and NYP. We also have specific people that we can direct you to should you decide it, or if you have a particular need, so we're happy to do that. This is a question I get often, which is how often can I get an epidural injection? And we try to limit these to around every 4 to 6 months if we can. You can repeat them. It is not, though, meant to be done year after year after year. There are some nuances to that, and of course we can talk to you about that. But you can repeat them, but the idea is not to have to do them serially forever. And then the question of which treatment is right for you. There's so much that goes into this, into whatever treatment is right for any individual patient. It requires us to see you, do an exam, see exactly where the stenosis is occurring. It is truly an individual matter. And so without, that's also the reason why I said I can't really answer individual questions, because without seeing everything and seeing the whole picture, it's hard to meet that recommendation. But certainly we're happy to walk through that process with you. So I work out of the Ox Spine Center at Weill Cornell, and this is truly a multidisciplinary clinic of multiple specialties. So we work closely and work on the same floor as our orthopedic and neurosurgery spine colleagues, physical medicine and rehabilitation. My background is in pain management and anesthesia, so we're there, radiology, neurology, and also physical therapy. And the benefit of going to a spine center is that there's a lot of communication that occurs behind the scenes that you may not necessarily get at another facility. We work with these people every single day, and it's a lot easier. We talk through cases almost on a daily basis, and we can share information, and we can expedite referrals should they need to be done. And so that is really the benefit of going to kind of a multidisciplinary spine center as opposed to kind of individual doctors in different areas. Our clinic we're located in 3 different areas. That's our office number, and so if you have any questions, if you need an evaluation, that would be the number to call. And we have 3 facilities, so all these places we have a presence in. So the main spine center is on 59th Street, 2nd Avenue. But we also have clinics in Lower Manhattan, which is also where I practice, and also on the west side on Broadway. I think it's on 86th and